A very good evening to all. I am Nishita from CLIRNet. CLIRNet is India's largest live digital CME and doctors generated medical content platform. Today, we all have gathered to raise an awareness about Omicron variant. The Omicron variant has ushered panic responses globally because of its contagious and vaccine escape mutations. Omicron multiplies around 70 times faster than the Delta variant in the bronchi, but the evidence suggests it is less severe than the previous strain, especially the Delta variant, and is 91% less fatal than the Delta variant, with 51% less risk of hospitalization. Overall, the extremely high rate of spread combined with its ability to evade both double vaccination and body's immune system means the number of patients requiring hospital care at given point of time is out of great concern. These are the very short glimpse of Omicron, but we have with us our expert doctors to dig out inside of the COVID-19 and Omicron. CLIRNet has taken the initiative to arrange for a digital CME on panel discussion between two nations, bilateral summit on Omicron variant, India and South Africa. Now, I would like to invite Dr. Aviral Roy, who doesn't need any introduction, but it is my honor to introduce Dr. Roy. Sir is consultant intensivist, Department of Critical Care, Medica Super Specialty Hospital, Kolkata. Sir is also formally associated with Cabell Huntington Hospital, West Virginia, USA. Dr. Roy is known for helping patients who needs assistant devices to perform essential functions like breathing and blood circulation. Devices include a mechanical ventilator, medical cardiac support. He has also done numerous research and has co-authored multiple book chapters, scientific papers, and different articles in the extracorporeal membrane oxygen, that is ECMO, electronic medical records, and use of ultrasound technology in the ICU. His areas of expertise include H1N1 pneumonia, dengue fever, ARDS, septic shock, heart failure, use of ECMO for lung failure, and neurocritical care. Now, I would like to hand over the session to Dr. Roy to introduce our today's honorable speaker, Doctor. Over to you, sir.
Thank you, Nishita, for that extremely glowing introduction. I don't do justice to it, so that's very fancily written, but I do appreciate it. Thank you, everyone. Welcome to today's, let's call it summit. I am very humbled and privileged and proud to be able to introduce such luminaries and such world-renowned physicians to today's summit. We're going to be discussing everything you want to know about Omicron, from a technology level, from how it came around to how to manage it, what's the guideline, what do the guidelines say, things you should be doing, things you should not be doing, and most importantly, also we will look into the impact on children. It's a sector of the population that seems to have been relatively spared by coronavirus disease so far, and we could not be prouder, and we must thank CLIRNet for arranging this wonderful set of doctors and world visionaries and world leaders. It's not just enough to call them doctors, but visionaries and world leaders over here today. I'm first going to start with Dr. Angelique Coetzee. She probably is one of the most famous doctors in the world right now. She's the chairperson of the South African Medical Association, but globally she's renowned also for the fact that she was one of the first physicians to raise the alarm that there possibly might be a new variant of the SARS-CoV-2 virus, also known as the COVID-19 coronavirus. She's a South African healthcare expert and works as a general physician in Pretoria. She has been spoken to and interviewed and has led multiple discussions globally about Omicron disease. and is leading and one of the leading experts in the fight to help educate the world about Omicron. She's also led the fight at South Africa against Omicron, and is going to give us a little bit of introduction or a little bit of knowledge and guidance on how to fight it. Dr. Koetze?
Thank you so much, Dr. Roy, and thank you so much for asking our opinion here today as well. And, you know, I'm always amazed that people are listening to us, not used to that. You're used to your patients and that's it. And then you're used to fight and to get healthcare for your people. But again, thank you so much. You know, Omicron, a very, very interesting variant. And, you know, yesterday it came to my mind that Omicron is actually a hit and run type of viral infection or variant, because if you look at what we have seen right in the beginning, so the first cases was on the 18th of November that I, from a clinical perspective, noticed that these complaints of these patients in the clinical picture, with them testing positive, we do rapid testing in our surgeries, which takes us about 2 minutes to get the result. Didn't fit the Delta picture, and I then alerted the advisory committee on vaccines, because I'm part of them, and that was by the afternoon, because, you know, then I saw 7 patients, you know, for one day, when you don't or didn't see for at least nearly 8 weeks any Omicron or any Delta patients or any positive COVID patients. This was a bit of well, something is wrong. And on that day, I also saw 2 children. And interesting, while we then alerted, and simultaneously one of our Lancet lab assistants also picked up that there was something on the PCR that didn't fit the normal testing. So it was everything that just came together. But while our scientists were trying to work out the sequence and what is going on, we as clinicians, unfortunately, had to see the patients on a daily basis. We have, from a clinical perspective, needed to sort out, you know, how we're going to look at these patients. What are we going to do? Is it the same than Delta? I know I spoke with Prof. Karim, and he said to me, Angelique, this is scary. It looks like there's a lot of mutations we don't know. But it didn't help us, on the other hand, because the patients still come in, and what do you do? Very interesting, but I will, a bit later in the talk, allude around this. And this is how it started. And I think the thing that angered us in South Africa, and also from the medical association side, was when, after our scientists announced the new variant, within 24 hours, United Kingdom, you know, slammed us with a restriction regarding traveling, and that didn't go all very well with us, because by that time it was nearly day 7, 8 that we are seeing the patients, and it was definitely not in the same way than Delta, and that's when we that's when we started to speak out and say this is unacceptable. And yeah, this is the short story about this. But again, I think going forward, we really need to start looking at primary healthcare and the clinicians at working with these patients. And we need to start to listen to our doctors on the ground level, because they are seeing very important clinical pictures. They are the ones that, in the end of the day, need to treat the majority of the patients. So yeah, but with this short words, I'll give back to you.
Thank you, Dr. Koetze. So just to clarify, when you say that the lab called you saying there's something off about it, is this the S gene drop that they were seeing on the PCRs? They're saying this doesn't need to fit, you know, Delta does not do this. Is that what you thought might have been a new variant? Or along with the fact that, you know, you were now seeing entire families getting sick almost simultaneously, which one do you think it was that really set off the alarm, or it was all of this?
I think it's a combination, Aviral, but it's a very good question, but it's a combination. I realized how important actually clinical medicine is, and I think it's neglected across the world. that people doesn't really listen to patients anymore. Patients doesn't really come into surgeries or consulting rooms only to see specialists. There's a disconnection between what happened at primary healthcare level and at specialist level, and we are much too much hospital centric than trying to speak to the average person out there that comes to us. But very interesting, yeah, but it's a combination.
Perfect. Thank you, ma'am. And the other discussion that the other point you brought up regarding, the use of testing in a completely globalized world, and as using testing as a way to keeping out variants, how effective of a mechanism is that? We'll actually discuss this in our discussion of once everybody has had a talk, but that is an interesting topic. We say that because, the first case of Omicron that was detected in India was actually in a doctor in Bangalore, whose sample was actually collected on the 24th of November. And that is 2 days prior to Omicron even being declared a variant of concern by the WHO, which already meant you had community transmission ongoing even prior to, was there any benefit of having, complete lockdown of air travel and, traveling from certain regions of high prevalence?
I fully agree with you on that. That's why we also from South Africa said, and I know I have said that this, especially on the media in the UK, that you cannot stop. You close your borders. This virus is already in your country. You just didn't know it at that stage. And you cannot control a viral infection, and not with Omicron. It's got certain characteristics. Again, if you look at viral infections, it's still the basic things that we have been taught, even at school level. They still teach, hopefully they still teach students that normally a virus is fast spreading. You can be infected before your symptoms starts, and how do you stop and droplets and hygiene and all of that stuff. It's still back to the basics. I call it the common sense approach, which we sometimes forget. We wanted to make it very, very complicated. Very.
Okay, perfect. So in summary, if I can just summarize what Dr. Coetzee has said, back to basics. Do the important things, wash your hands, wear your masks, listen to your primary care physician, and at the end of the day, patient care and direct patient care is the most important. The most important person you have to learn about Omicron is, from the doctor's point of view, is your patient. No amount of books, nothing's going to help you. You got to see the patient, and that's where you're going to discover new variants. Thank you, ma'am. We'll come back again. We'll circle around when we have our discussion. We're now going to move to Dr. Prasad. Wonderful. So Dr. Rupali was a senior ID fellow in the Department of Adult Infectious Disease in Auckland City Hospital, New Zealand, and also the Diploma in Tropical Medicine and Hygiene from Lima. I'm sure that's an entirely interesting story, and we would all love to hear about it if we had some time. She runs the annual course at the Clinical Tropical Medicine at CMC Vellore. She's also got formal training in transplant infectious disease from Henry Ford Hospital, Detroit, and has established multiple transplant-related services in her hospital and transplant infectious disease conferences in Vellore, Chennai, and Ludhiana. Her passion seems to be antimicrobial stewardship programs at the primary, secondary, and tertiary care levels. This is something that is really, really important, and the need of the hour in a country like India, where we are famous for NDM, New Delhi metalloproteinase, and so many other antimicrobial resistance mechanisms that have turned up. What we do not see over here, and which I'm happy to know, that she's also the chair of the COVID guideline committee in India that releases all the COVID guidelines. So doctors, who to ask questions to if you have got concerns with the COVID guidelines. Anyways, Dr. Priscilla Rupali. So I guess what I wanted to discuss is, how do you maintain, so COVID units become closed, right? And now this is more of a doctor and nurses interaction. How do we maintain good hand hygiene? Because nurses or doctors or anybody who's in the COVID unit for the matter believe that they've got gloves on and now everything is clean, doesn't matter what they touch. What's the challenges of maintaining hand hygiene, antimicrobial stewardship, or for the matter, basic hygiene in the COVID units? Because we saw it wasn't COVID necessarily that was killing patients. it is a secondary infections, especially in a country like ours, like India. It was their secondary bacteremias, the secondary pneumonias, or in some cases secondary fungal infections. So what's your thought on this matter?
So thank you for asking me that question. As you rightly said, antimicrobial stewardship and rational use of all antimicrobials is one of my passions. So I think we have to look at the COVID pandemic as we did in 2020 and how it is now. So we are 2 years from there. And when it first came out, there was widespread panic. And, there were no guidelines. People didn't know what was happening. We had, varied kind of opinions being offered as to whether it was a, airborne infection versus a droplet. So a lot of the protocols that we put forward during that time have actually held us even today. So, I mean, the usual common sense approach, which I really liked what Dr. Coetzee had mentioned, I think holds good even today. So whether it is wearing your personal protective equipment appropriately, maintaining social distance, triaging patients, controlling the crowds, and the engineering control mechanisms that we put in place during the first wave of the pandemic have actually held us in good stead. Now, with regard to OMICRON and how has it influenced infection control practices? Now, OMICRON, luckily for us, is a less virulent virus. So what has happened to us is that no one has actually come to the emergency department and to the outpatient departments. So as Dr. Coetzee mentioned, it's only the doctors, not so much in the ICU, but in the outpatients and in the ED who are facing these issues. Yes, how have we motivated them? So obviously by this time, everybody is, kind of bored of listening to the multiple webinars that we hold in our hospital to reinforce infection control. The few things that we have actually done is have regular awareness programs. We have what is called as the pulse lectures. So they call as the COVID pulse lectures, where each department of the hospital is encouraged to attend this. And, it's held in multiple sessions, various parts of the institution, which is right from your doctors, nurses is one group. Then we also have the other groups we take multiple reinforcement sessions for them, train them as to how to wear appropriate equipment. The other thing we've encouraged is actually a buddy system, because, you kind of get bored. So you encourage a buddy system where you say, okay, hey, you didn't do this step correctly. We've got huge posters, huge laminated cards where people know exactly what to do, because, when you're tired at the end of a shift, your brain isn't really working very well. So if you have big laminated cards which tell you step 1, step 2, step 3, you don't really have to use your brain so much. You just look at it and do the things as mentioned there. So yes, it's been a challenge. Luckily, it's less of a challenge with OMICRON than it was with the Delta wave, which really decimated us. But I think healthcare workers are much more careful now. We've also, through our information that we've generated, not just in our hospital, but also data gathering all over the world, we know situations which are high risk. And those are the things that we always do a risk assessment. So we periodically, when people do become positive, at least the last year during the Delta wave, we check with them, okay, what happened? How did you become positive? What are the situations surrounding your infection? And by that, we've actually been able to identify high-risk procedures, high-risk, things like having coffee, having meals. All that has now come out from WHO and various guidelines, but we did that on a real-time basis, that we were able to demonstrate to our healthcare workers that this actually works. So please follow these precautions. With regard to stewardship, I think that's been really challenging, because our traditional model of stewardship has been a post-prescription review and feedback. So you go to the patient's bedside, see the patient, talk to the doctor, dialogue with them and say, look, this is what the culture shows. Can you please reduce the antibiotics? So that has been actually a huge challenge for us. What we did is we reverted to a system of, luckily we have electronic medical records. So we're lucky. I'm sure it's not as easy elsewhere. We used to look at the prescriptions that were ordered and then correlate them with the cultures. We call back and then we used to put alerts on our electronic medical records saying, look, the antibiotic has, the cultures have come back, patient has no infection, patient is better, please stop antibiotics. So we did that. The second thing we did was to convince the doctors to stop antibiotics. We actually started using, what we found is using procalcitonin to discontinue antibiotics with the same cost as continuing the antibiotics for a couple more days. In fact, it was much cheaper. So we use procalcitonin quite liberally to actually encourage this stopping of antibiotics. So those are the few things that we put in place. With regard to fungal infections, and I think that's an interesting question. To date, I think though we had such a huge number of COVID-associated mucormycosis, nobody has really been able to pinpoint what exactly the reason is. However, a few things that have been borne out in multiple cohort studies and case control studies in India, the moment a patient is diabetic, the moment a patient is on steroids, you have a high ferritin. Now, whether that could indicate iron overload versus an acute inflammatory marker, whatever it is, those are the three things which pointed us towards saying, okay, look, this person is at a higher risk of getting Mucor, so let's watch out and be vigilant. Those are the few things that we did. We are a tertiary care center with good ENT, and a multidisciplinary clinic was actually established by my department with regard to COVID management. So we had ENT, infectious disease, sitting together and making plans for every patient. So those are a few things that we put in place.
Perfect. Thank you, Dr. Rupali. So I guess we just saw the new guidelines come by the government of India, right? And I'm going to talk about a molecule called tocilizumab. We just came out with the new guidelines saying, you know what, rule out fungal infection, rule out bacterial infection, rule out TB, make sure they're not on any other immunosuppression, preferably do not give too many high-dose steroids. And it seems pretty, at least to us, right? Maybe we are in tertiary care centers, we have a high load of COVID patients. It seems pretty straightforward, pretty common sense, as you said, right? Okay, yeah, of course, we're going to give immunosuppression that is optional. You would want, especially with something like toci, which has a pretty long duration of immunosuppression, almost 3 to 4 weeks. That is what you would do. But was there any correlation in any of your studies between giving tocilizumab specifically and the onset of fungal infections in these patients? Or
no, so there was no. We are, though we are a tertiary care center, the clientele that we usually serve are actually somewhere in between. So we serve the low middle class to the really poor. So we actually use tocilizumab pretty sparingly, but we use steroids definitely where it was indicated. But in the cases, even then, we have had about, nearly 150 cases of COVID-associated Mucor. And all this was studied. We have not really found any correlation of tocilizumab with the fungal infections. Actually, Tanu, Dr. Singhal also has managed quite a few. So she may be another person. I think, hospitals which use a lot of tocilizumab may have a little more experience. But in our experience, for the patients that we used, we did not find a correlation.
Okay, perfect. Thank you, Dr. Rupali. Our next speaker, and I'm very proud to announce, is Dr. Tanu Singhal. She's an MD Pediatrics and an MSc, a Master of Science and Consultant Pediatrics and Infectious Disease from the Kokilaben Dhirubhai Ambani Hospital in Bombay. She's been awarded one of Bombay's top docs awards in infectious disease in multiple years, 2012, 2014, 16, and 19. She's also got the Frederick Burgeroyd.
I think we can let this be. I think that's enough.
I'm sorry. I really wish not to embarrass you any further. I'm sorry. You can look a little bashful over there, but sure. Basically, there's no other superior authority in India than Dr. Singhal to talk about pediatrics and infectious disease. So thank you, Dr. Singhal. So I guess my question to you is, we've had 2 waves of COVID. Actually, the first wave was kind of a long, drawn-out process, so you could almost say 3 waves. But this is the first time we're starting to see, an increasing level of children who are now coming into the hospital with COVID and COVID-like symptoms. So, I guess I wanted to ask you, especially for all the doctors out there, and how to talk to parents of such patients. What is it about Omicron that presents in children in both the outpatient setting, in the inpatient setting, and are there any symptoms that they should really get worried about?
So I think one thing which has stayed almost constant over the past 2 years is how children have been affected with COVID. And fortunately, because of certain immune mechanisms, children are able to fight the SARS-CoV-2 better. And even in the first wave and in the second wave, we found that children were getting infected. They were having symptoms, but they were really not landing up into hospitals. And pediatric deaths contribute to only 0.3% of the global COVID deaths, whereas they contribute to almost 30% of the population. So, and that is also true now for Omicron. Now, the only difference this time that we have seen, one is that the number of patients are large. And that is also because anyway, you have 4 times or 5 times the number of cases happening every day. So obviously, you see a lot more infections in children. And a little bit, I don't know whether there's really any data out there or whether some analysis has been done. But our first impression is that the fever that we are seeing this time is much higher than we saw in the first and second waves. And there have been children who are coming in with febrile seizures because of high fever due to COVID. But also the good point about it is that in most children, the fever is settling in 1 or 2 days' time. They do need a lot of aggressive antibiotic therapy with ibuprofen, paracetamol, and tepid sponging. But then 2 days later, the children are fine and they just bounce back and they are all good to go. So that is the first thing I would like to say, is that parents need not be worried about Omicron in children because it's usually like in adults, it's a mild illness, except that the fever is high and bothersome. Now, as far as children coming into hospitals, we've not really had any COVID pneumonias so far. And children who are getting admitted to the hospital are those who have other illnesses but are also incidentally testing positive for COVID. So they are the ones who are getting into hospitals, or we have children who are highly immunocompromised because they are transplant recipients or who are on cancer chemotherapy, and then they get COVID. And even if it is mild, you want to admit them into hospitals so that you can give them antiviral therapy. So that is how it is. Really, hospitalizations are mostly incidental COVID. The other thing which we still don't know about is about multisystem inflammatory syndrome, because we did see quite a few cases after the first wave and after the second wave, but we don't know whether the same is going to happen after Omicron, because it seems to be a little different virus as compared to the other variants. It does not cause that much of a cytokine storm and immune dysregulation. So hopefully we'll have less MIS, but one can only talk about that once the peak is over, which we are not yet. But I don't know from South Africa if there are any reports, because now their peak is over, and whether they're seeing cases of multisystem inflammatory syndrome. So that is what we are really kind of concerned about at this point in time, whether we will see a surge of MIS. But otherwise, acute COVID in children, except for the high fever, really not much to worry about. And as far as the point about when would you tell parents to get their children, one is that, if the child is not well even 2 days after the fever has started, then definitely that would be an alarm bell. And that is not so much because of ongoing COVID, but we don't want to miss a co-infection. Because, you can have COVID along with other illnesses also. So that means if after 2 to 3 days, the fever is not coming down, that is when we actually investigate these children to make sure we're not missing something else. Or if the child becomes breathless, tachypneic, then we tell them to come to the hospital. We don't encourage a lot of saturation monitoring in small children, because inevitably, it's not very accurate at home. And then you get a wrong reading and the parent gets very anxious. But in older children and adolescents, we tell them, yes, if the child is sick, you can monitor the oxygen saturation. And if it drops below 95%, you need to reach out. We are especially more careful in counseling parents of children who have comorbidities, because healthy children will not really get any kind of complications. But if the child has chronic cardiac, lung, kidney, liver disease, or is immunocompromised, they are the ones where we tell them that you need to be more watchful.
Okay, ma'am, perfect. So I guess it doesn't make sense with Omicron, but for children with comorbidities, like I'll give you an example. Somebody called me, has a child with known autosomal recessive polycystic kidney disease, grossly overweight. We are talking, and also weighs like a BMI of close to 31 or so. So we considered giving them antibody cocktail therapy, because at that weight, basically the pediatrician came to us, he's almost an adult. He was reaching adult weights and adult doses, and they did not have as much experience with those therapies. So once you hit those, the treatment protocols for children with COVID-19 and who are at high risk for progression, I guess they are very, very similar to what you would do for adults.
Yes, but even one thing is that the risk of progression is still not as high as adults with comorbidities, because most children with comorbidities are also able to handle COVID-19 fairly well. So maybe we are not as aggressive as how adults would be. The second thing about the monoclonal antibody cocktail, yes, we used it after the Delta wave because it is approved in children above the age of 12 years and with a weight of above 40 kg. So yes, so for example, we had a child who had SMA, spinomuscular atrophy, who had, lung dysfunction, who had respiratory involvement. So that is a child where we used it. But or maybe a patient who's a transplant recipient, we would use it, but not in all children, so just chronic kidney disease, chronic liver disease, we were not aggressive in using the cocktail because we, from our experience with knew that even these people would handle it well. On the other hand, what we would do for some of these patients is, or even younger children where you can't give the antibody cocktail, is to give early remdesivir if their fevers are not getting better in 2 to 3 days and we find that there are adverse effects. Now with Omicron, things have changed because now we know that the monoclonal antibody cocktail is not going to work for these patients. So that is out. And other antiviral drugs like molnupiravir are not approved for children. So at present, our protocol for managing children who are having very severe comorbidities, not the mild ones, is to keep them in hospital for observation and give them early remdesivir. Because you can use remdesivir, in any child who's weighing more than 3.5 kilos, you can give remdesivir and you have dosage guidelines.
Okay, wonderful. Thank you so much, ma'am. So we heard right there, folks, children are relatively good. Most of them, their fever will break after maximum of 48 hours. However, if after 48 hours, they still continue to be very symptomatic, or if there's a developed warning signs such as tachypnea, grunting, excessive work of breathing, altered mental status, hypotension, that's when you should consider bringing them in, because they're always prone to getting comorbidities or not comorbid, co-infections from other viruses. And, they might have a bacterial pneumonia and the COVID is only a red herring. It's a coincidental finding that they just happen to have. So again, like as Dr. Koetzi had said, back to basics, do your basic medical care well, do your basic assessments well on your children, and you should be good to go. Dr. Singhal, I'll ask you one question because unfortunately, Dr. Priscilla had bounced this question to you for further analysis. And Dr. Gray, I just got a message, is running a little late. So what is your experience with the mucormycosis and COVID-19 and what are the risk factors of patients that seem to make them more prone to getting Mucor?
So if we look at our in-house data, we've managed about 1,500 to 2,000 patients with severe COVID-19, and we had one case of mucormycosis. Okay, so probably because we use steroids rationally, we had controlled their high sugar levels better, and we had good air conditioning system in our hospitals. We didn't see it. All the cases of mucormycosis that we saw in our hospital, which must have been close to 40, have come from other places. They have been treated for COVID elsewhere, and then they have been referred to us. And the risk factors which we found was, one was basically diabetes. The second was excessive and irrational steroid use. We did look at tocilizumab as a risk factor, but we didn't find it in any patient. And even in all the patients that we used tocilizumab in our hospital, we didn't find an increased incidence of infections compared to what happened with steroids. So yes, and also the point is that tocilizumab has to be used relatively early in the course of COVID, by which time your secondary infections don't really set in. You do it in the first 2 or 3 days when your patient comes to you. So most of the times there's no contraindication to giving tocilizumab, but you have to watch these patients carefully. But we feel that if you use tocilizumab the right way, you might actually reduce the risk of infections, because your patient may not go on to the ventilator and may make recovery faster, which are actually the risk factors for secondary infections. So coming back to mucormycosis, these were the risk factors. In fact, we found people who had mild COVID, but just because a CT scan was done, which showed multiple, some ground glass opacities, it was labeled as COVID pneumonia, and despite not being hypoxic, were given steroids. Also, there were patients who received large amount of steroids for prolonged duration, sometimes at home with no checking of the blood sugar levels. And also the third factor which has been responsible is improper air conditioning systems, because there are a lot of places which were converted into makeshift COVID hospitals where the air conditioning may not be right, or the tropical climate of India, which caused these people to inhale these spores. And it was definitely not related to humidifier water or contaminated oxygen or contaminated masks, as was the news going around, or maybe even cow dung, because I think I read somewhere that, the use of cow dung predisposed. So that was not so. And, since June, we've not seen a single case of mucormycosis, because I think the message went in that, you can't use your steroids improperly, and you have to check the sugar levels. And I think everybody became aware, because we have been seeing a smattering of cases of COVID even after June, but we've not seen mucor.
Ma'am, it's like you almost read my mind. My next question was going to be, what do you think about this theory of, mucormycosis spores being there in the nasal, in the water that they use for bubbling your nasal oxygen through? But I'm glad that you already brought that point out. Dr. Gray is running a little late, so we're just going to have a quick discussion. I don't have any new, I'm just going to open my question slide. Just give me one moment. But in the meantime, I'm glad I have two infectious disease experts over here. And I'd like to bring up a point that Dr. Coetzee had brought up. How do you're a world leader. In a hypothetical situation, you're a world leader. How do you control, A, how do you detect new variants, A, and B, how do you control the spread of new variants? Because we saw what happened with OMICRON. They're testing 72 hours prior to getting on an international flight, they're negative. And then they land in a new place and they turn positive within those 72 hours, plus another 10, 14 hours that they're actually in the flight. And that was one. And two, by the time you even detect a new variant, it's already undergoing community spread in multiple nations, like as was the case in India. Our first case was community spread with no known travel history, no known contact history. So as a world leader, how do you even control, what's your plan, or what do you think would be a rational approach rather than the current approach? It seems to be predominantly driven by fear of trying to keep out this variant at any cost. I'm going to open this up to Dr. Rupali as well and Dr. Coetzee as well. Dr. Coetzee, I'll have you go first.
Let me go first. Great. Very important question that you ask. Again, you can see I'm a clinician. So I would always say, how do you know there's a new variant? Yes, you can wait to see cases, all of a sudden, a lot of people getting sick. Or you can have a very, very good relationship with your doctors who are at ground level and telling you, listen, something is wrong, and starting to engage, and then the signs should definitely follow to work out what's happening. So there should be a relationship, which I don't always think there is. And so the signs should meet the ordinary worker at ground level, doctor. So I think that is very important. The second thing that you need to know is, once if you understand the clinical picture, it will help you to understand how are you going to test for this viral infection. So with Omicron, we know that you, even on the first day, I always say, if you wake up this morning and you immediately rush to get a rapid test, to do a rapid test. It can still test negative because there's not enough viral load in that test. And then you say, I'm negative, but then you spread it very nicely. So it's also then to start to empower the people to let them know what is available out there. When do you test? What do you test? When do you go to the doctor? What symptoms do you need to look out for? When do you go to the hospital? We very seldom take the people with us on the journey. So for me, it is extremely important. Once if you understand that, you will start to control the virus much better. But we should stop this fear thing. And I keep on saying, what we need to do is we need to say, okay, there's 50,000 people tested positive today. Great, we thank you that you tested. At least you tried to make something. 50,000 of you are not in the circulation anymore. So it means your rate of spread of the virus is going to come down. And then next question is, I would now like to say to you, so many people are in ICU, so many people are in high care. Please take care. But instead, what we do is we say, this is the positivity rate, and then we create fear, and we say the hospitals are overwhelmed, and then I'm asking, the hospital or the ICU? And why are they going to a hospital? Because what we see, it is a predominantly mild disease that's actually supposed to be treated out of hospital. So there's not good communication. So if you want to stop the spread, first of all, you need to start to communicate at the right level with the people with the right message. I hope this makes sense.
It makes perfect sense, Dr. Coetzee. So just to summarize, test, because if you do test positive, you can be removed from the general population circulation, at least quarantine at home, and the likelihood that you are going to infect somebody else is lower. So I guess I'm going to carry that point forward and ask Dr. Rupali this question. We just saw the most recent COVID guidelines come out saying that, if you have a positive contact, somebody say in your own family is positive, do you test only the high risk contacts of that person, or do you test everybody, including the asymptomatic low risk people? And what do you think about it as a strategy? Because the trouble then becomes, as Dr. Coetzee so well put forward, is how you want to try to reduce the spread of disease. Like you say, flatten the curve. How are you ever going to be able to flatten the curve as preventing a rapid increase in or rapid surge in cases if you're not able to get patients out of not even get people out of circulation, so not spreading it in community? So what do you think, Dr. Rupali, on, testing extensively, or versus just, if you have a positive contact, just quarantine anyways, and if you do get symptomatic, go ahead and then test?
Okay, so that is going to be a difficult public health question to answer. So I think the most important thing, I think if you read what Dr. Coetzee was mentioning, I think you need to be sensible. That's the first thing. So even when we're testing, we test sensibly. We know where the virus is likely to create havoc. The virus is going to kill some people. Those are the people we definitely need to test. So high-risk contacts, definitely. I think high-risk contacts, you have to test them because the cost of not testing them is very high, because you'll end up with, people having severe disease when it could have actually been handled much earlier. Now, with regard to people, I actually quite like our recent government guidelines because I think they're sensible, finally. So I feel that I think we are going to be overwhelmed with the systems. And like Dr. Coetzee mentioned, fear-mongering has become a way of life. Everybody who's anybody has an opinion, and everybody, I've had people just today, I've had at least 3 people asking me, what do you think of this WhatsApp forward? And it's frustrating because we are trying to be sensible here. We're trying to have a response which will take care of people. I think that's the most important thing. So if they are asymptomatic, yes, tell them to isolate themselves if they've been in contact with that particular person. Can we really test everybody the person comes into contact with? There is no way you can, because that person would have probably been in touch with like 20, 30 people. If you're anybody like me, maybe I'm too social, but the thing is, you cannot test everybody. So I think you have to use your judgment. And that is exactly what the ministry guidelines Safe. High-risk contacts, definitely. Healthcare worker contacts, yes. Asymptomatic, watch them, isolate them, let them quarantine themselves. If they become symptomatic, by all means, test them. But otherwise, let them just stay home for 5 days and take themselves out of circulation so they don't really spread the disease around. I think that's the way to go. Our hospital is unable to cope with the number of tests that you ask. In the Delta wave, I think they went mad. Everybody was like tearing their hair out. So I think we're trying to move away from that and trying to test sensibly this time, which I think is a good way to go.
Okay. I think that's a very well balanced and a very pragmatic answer by Dr. Rupali. So that's important, right? Because testing indiscriminately will at some point result in your system breaking down. So test people who are symptomatic, test responsibly. But yes, if you are symptomatic, definitely get tested. And more importantly, use common sense. If you are symptomatic, please don't take a paracetamol and get on a plane, because I see people do that all the time. Somebody's symptomatic, they take 2 paracetamols, next thing you know, their fever is back down to normal and they get on a plane and oh my God, for all you know, they probably got on the plane, had a chicken sandwich on the plane as well by taking their mask off. So common sense is really, really important. And I think that's actually the toughest part in our current, in the public response to the pandemic. Continue to do simple things, hand washing, hand hygiene. If you're symptomatic, get tested, stay at home till the results of your test come out. Just because you say, you know what, I got tested, my results are not back yet, and I'm going to go out. If you're symptomatic in the middle of a COVID surge, I think assume you're COVID positive till your test tells you otherwise. I'm going to ask my next question to Dr. Singhal.
Yes.
So this is coming from our online audience. Is there any way to distinguish between influenza or any other respiratory viral disease from Omicron? Now that it's winter, or even allergic viral rhinitis, because the air quality in cities like Bangalore, not Bangalore, sorry, but New Delhi, or for that matter, any city in North India and even Calcutta where I am.
Well, the straightforward answer is no. Because, Omicron is a little different from the other viruses in that it has a lot of upper respiratory, other SARS-CoV-2 variants, that it has a lot of upper respiratory involvement in the form of sore throat, runny nose, etc., which can be there with any respiratory viral infection. But having said that, at this point in time, there is such a tremendous surge of Omicron that anybody who's having these symptoms is COVID unless proven otherwise, because that's the virus which is going around. And our experience has been that whenever there is a large surge of infections, it pushes out the other viruses. So at this point in time, and in this very time, if somebody is having symptoms, it is more likely to be due to COVID than any other respiratory viral infection. And particularly so if you have multiple family members who are infected, or if you have one family member who has tested positive, then you know that this is likely to be COVID only. In the first and second waves, we saw this loss of sense of smell and taste, which was more commonly seen in adults, not so much in children because they can't report it. But that was quite a specific feature of COVID. Because if you had that, normally no other viral infections they may cause a loss of sense of smell because of the nasal congestion, but not taste. But with Omicron, we've realized that even you don't have this, it's not commonly seen. So that also doesn't help us in making that differentiation. For practical purposes, if somebody comes to us with fever, any child who comes to us with fever, any adult with fever and upper respiratory symptoms, we think that it is COVID and we test them. Now, if that test has come negative, it can still be COVID, because we know that the RT-PCR has at best a 70% sensitivity. So then if the person is not doing well or is having continuous symptoms, then you start testing for other respiratory viruses, because the cost of the test to test for influenza, RSV, rhinovirus is quite high, and you can't do it in OPD patients. In inpatients, however, if you have a child with a lower respiratory illness and is tested negative for COVID, then we test them for other respiratory viruses. So that's what it is. So And even you can allergic rhinitis. How do you differentiate between allergic rhinitis and an infection? We generally ask for systemic complaints. So if the person has just a runny nose and is not having fever, not having fatigue, not having body ache, and has a past history of allergic rhinitis, this could well be it, because you would get some other systemic symptoms if you had a respiratory viral infection. So that's how we differentiate. Now, what was found earlier with the first and second variants, there was a study which was done early on in the epidemic where they compared flu cases with COVID cases. And there they found that fever was higher in flu as compared to COVID. That was at the time of the first wave, but I'm not sure whether that holds true now.
Perfect. Thank you, Dr. Singhal. Hey, welcome.
Hi.
Wonderful, ma'am. Professor Dr. Glenda Grey, it's my absolute honor and privilege to introduce her and for her to join us on this esteemed discussion. She's currently the president and CEO of the South African Medical Research Council. She's one of the most influential people in the world as per Time magazine in 2014. And along with James McIntyre in 2012 was actually awarded the Nelson Mandela Health and Human Rights Award for pioneering work in the field of HIV, especially in mother-to-child transmission. She's been listed as among the most powerful women in Africa by Forbes Africa in 2017. She's also a research professor of pediatrics at the University of Witwatersrand and the director of perinatal HIV unit. She's received the Femina Women of the 90s Award for her contributions to perinatal HIV research and the IAPAC Hero of Medicine Award for work done in the field of HIV transmission and treatment in adults and children. And in 2009, along with James McIntyre, please forgive me for the pronunciation, the Magali Mann Lectureship at the CROI in recognition of the HIV research in South Africa. Welcome to our program, ma'am. Do you have a presentation, or we were just doing a general discussion? So you'd let us know how you'd like to do it.
I do have a little presentation. I won't go through it all, but I just thought I would make some points. Let me just, can you see my presentation? Can you see it?
Yes, ma'am, we can see it. Yes.
So I think it's very important in South Africa, and I guess in India as well. We have a large amount of HIV infected individuals and immunocompromised people. And obviously with COVID-19, we have seen people who are HIV infected, particularly if they have, they're not well controlled, to have more morbidity and an increased risk of dying. So it's very important to make sure people who are HIV infected are diagnosed and who are also on their antiretroviral therapy. So this in terms of COVID-19 prevention, at a global level, in the first generation of COVID vaccines that we have, there's our biggest deficiency in this portfolio is how to address the issue of COVID-19 in immunocompromised hosts, particularly people with HIV. So there's about 30 million people with HIV at a global level. And in addition to that, there are about 20 to 30 million people with organ or bone marrow transplants and chemotherapy. At a global level, there's very little data on how what the vaccine effectiveness is amongst HIV-infected individuals and whether monoclonal antibodies will work. And if you are immunosuppressed or have HIV, do you need more boosting, and do we need a more frequent vaccination? So I think the bottom line is that we have no evidence-based data for COVID-19 prevention in immune-compromised patients, particularly HIV-infected. And a lot of the work that we do and our recommendations are empiric in this area. So why are we interested in people who are HIV infected or immune compromised? So first of all, we don't have substantial data that indicates immune compromised people are at risk of prolonged COVID-19. So we have data from certain studies that shows that people who are HIV infected may shed virus for longer, and if they shed virus for longer, obviously this is a problem for viral evolution. And we've already seen this, is that prolonged COVID-19 is associated with a multi-mutational change over the time, and also has been shown to be the area of multi-site viral evolution. We've also seen that in HIV-infected individuals, there's evidence of transmission in hospital or and rapid community spread. And so basically we have indirect evidence that HIV-infected people may be a source of variant spread in the community, which is obviously of concern. And so making sure we are able to address immune-compromised hosts, particularly HIV-infected individuals, is both good for HIV-infected people and good for the community. So if we can reduce the source of variant generation, it'll be good for humanity, and that's very important. So just looking at some data on the persistence and evolution of SARS-CoV-2, we see that that if you look at the top panel, that shows nasopharyngeal and bronchoalveolar lavage, and the PCR cycle threshold, and we can see that this is day 0, represents the day of first positive SARS-CoV-2 nasopharyngeal swab, and then you look at the ongoing, and just remember that days -5 and -4 are negative, and you can just see the persistence of shedding in immune-compromised hosts. So it's very important that we can try and understand how to prevent this. I'm not going to go through this, but this just basically shows some persistence that was seen in some people. So I'm just going to skip that. Skip that and then just basically show you, if you look at the viral loads by organ, you can see that if in postmortem analyses, there was a lot of virus seen in the bronchus and the lung, as compared to other parts of the body. And just looking at this data, you can see that in a patient with chronic COVID-19 infection, there was some evolution of mutations, and this has been some of our concerns in South Africa. And then it just shows you the likelihood of looking at patient sequences over time at different time points, and see how the virus has evolved in immune-compromised hosts. These were in the US, and these were not necessarily HIV-infected individuals, but points to the issue around viral evolution. And so basically, we also see convergent evolution as well, and obviously we also may see recombination, which we are very concerned about, whether there might be recombination of both Delta and Omicron in immunocompromised people in South Africa at a global level. So I'm let me just go to this slide, and this just basically shows some data from South Africa, where HIV-infected people appeared to have short clinical diseases, but when they were followed up, there was persistent shedding, and these were particularly in people who had advanced HIV and antiretroviral treatment failure, who were living at home in the community. And obviously, we saw the evolution of viral evolution. And so what's important for this is that there are tens of thousands of such people globally, which could be, which may be at risk of viral evolution. And this just shows you a phylogenetic analysis of 7 SARS-CoV-2 whole genome sequences from a patient with advanced HIV, and you can see that this is a big problem, particularly in advanced HIV infection. So if we look at vaccines in HIV infected people, there's very little data at a global level on how vaccines work with Moderna mRNA. At this moment in time in South Africa, we are doing an efficacy study in HIV-infected people using the Moderna vaccine to try and see what the vaccine effectiveness is. We don't have good data for Pfizer, and there's also very limited data for AstraZeneca or Chadox, and maybe in your year, because there's a lot of Chadox use in India, you may be able to tell me whether you've been able to look at real world effectiveness on that. And then in Novavax, we actually saw that there were more infections in people who were HIV infected in the vaccine arm as compared to placebo. We've also seen that there's also lower levels of immunogenicity, so less antibody responses and less CD4 and CD8 T cell responses. So just to look at the this was a study that was done in South Africa that looked at Novavax, and you can see the difference between people who were SARS-CoV-2 negative and then HIV positive, or SARS-CoV-2 exposed and not naive. And we can tell the impact of the vaccine effectiveness if you've had previous COVID and you get vaccinated. If you have a look, the biggest data set we have is in our Sasanki study, where we gave the adeno-26 vaccine, and we gave this to about 500,000 healthcare workers, and we have about 40,000 healthcare workers on our books. So we're able to really look at HIV in this group, and you can see that if we look at HIV vaccine effectiveness in HIV, and this is looking at various medical insurers in our country, you can see for COVID admissions, being HIV infected didn't impact on vaccine effectiveness, and people did pretty well. And we think this is because if you are HIV infected, you're more likely to present earlier to a hospital and less likely to wait at home to be treated. So vaccine effectiveness was maintained in HIV infected people against hospital admissions, and also a slight reduction in if you needed to have ICU or critical care. But what's very important is that we definitely saw that being HIV infected and receiving an AIIMS COVID vaccine, we saw reduced vaccine effectiveness against death. So we see 65% as compared to between 78 and 90% in people in people who are not HIV infected, who had who were not HIV infected but had some other comorbidities. So this is a very important slide, because it does show us that HIV infected people are more at risk of dying, even if they do get a vaccine as compared to their counterparts who might have one or two more comorbidities. This just shows you a study done looking at failure to seroconvert up to 2 doses of a mRNA vaccine in a patient with uncontrolled HIV. So this also showing you the immunological that they're not inducing good immune responses, which puts them at risk for not being protected against death or hospitalization, and also having to need more frequent.
Dr. Gray,
sorry
to interrupt you. Your audio is just cutting off a bit. So, if just any way to improve your audio quality?
Is this okay? Is this better?
Yes, much better.
No, okay, so just to say that if you're HIV infected and you're well controlled on your antiretrovirals, the immunogenicity is okay, and looks like the VE may be fine as well. And we assume a lot of these vaccines work, but there is lots of lack of anecdotal breakthrough information on clinical trials and effectiveness. And we see anecdotal data from US and Israel and the Emirates, where there's hardly any HIV. And quite frankly, we need a lot more data to understand how to optimize vaccine effectiveness in HIV-infected individuals. Now, I'm just going to stop there. I just wanted to just show you that data so that you could see that in South Africa, if we don't know that people are HIV infected and we don't put them on treatment, one, they will have more morbidity and mortality, and also if they get a vaccine, they may not have a good vaccine response as in other people with other comorbidities. So we have about 3 million people who are untreated in our country. So even though we have the largest HIV treatment program in the world, we estimate around 3 million South Africans who are HIV infected are not treated. And why is this important? I'm not sure if you know, but almost 1 in 5 South Africans are HIV infected. So it's a big problem in our country. And one of our concerns is that there may be viral evolution in a whole group of people in South Africa that are immunocompromised with HIV. So I think I'll stop there and maybe take some questions. And I'll apologize again for being late. There was a program with the president, and then it was supposed to start early, and they kept on pushing it late. And so I really apologize for coming so late to this important bilateral discussion. So my apologies again.
Thank you, Dr. Gray. Please do not apologize. We are in fact honored to have you over here, and that honor that you could make time for us. So I guess this is an important question that comes up, and I don't think something that we have thought about a lot, and we could probably open it up to our other specialists as well. So vaccines seem to work less effectively in COVID-19 and immunocompromised as especially acquired immunodeficiency syndrome or HIV positive. I'm guessing when you say HIV positive, I'm talking about people you're talking about in AIDS, in defined AIDS, or the CD4 count less than 200 is the ones we are really concerned about. So I guess, and with prolonged viral shedding, when do you think they may be asymptomatic, like you said? When is it a good time in somebody who are active immunosuppression? When do you release them from quarantine? You have an Omicron wave, you know it's not severe, they get upper respiratory tract symptoms, and 3, 4, 5 days later, they're fine. They're asymptomatic now. When do you say, you know what, it's safe for you to go to, you're no longer infectious? What do you think, what's the cutoff over there?
That's an excellent question. I think that it's hard to make specific guidelines for specific groups. So if you are HIV infected and you are not on antiretrovirals, one of the things that we have to make sure is that when we are treating them is that we make sure that we initiate them back onto their therapy, so that they both for their health and for the health of others around them. So I think putting them back onto treatment is very important. I would also suggest that once they are released from quarantine, and I wouldn't suggest that we change the guidelines, because a lot of people don't know that they're HIV infected, is that we counsel them on wearing proper masks that are well fitted, surgical if available, or N95 if available. Also to make sure that they continue to have optimal hand hygiene, and also work in areas where there's really good ventilation. So I think it's going to be very hard to differentiate on HIV status or immune status, particularly if you don't know what their HIV status is. But I think the principles of the pillars of making sure that they're vaccinated, making sure that they work in well ventilated areas, and making sure that they wear their masks properly and wash their hands are going to be the mainstay of managing people who are immunocompromised without exactly knowing their diagnosis.
Thank you, Dr. Gray. And I think this is a theme that we keep coming back to repeatedly. It doesn't matter. You're immunocompromised, you're young, you're a kid, you're an adult, you have comorbidities, you're a cancer patient on chemotherapy, you're a healthcare provider. By that, I mean, you treat somebody, you could be a regular person at home, but you're treating somebody with these problems. It always comes back to the same thing. Wear a good mask, wash your hands, stay in a well-ventilated area, and most importantly, get vaccinated. This is a theme that keeps coming up. Oh, you know what? Omicron is not as dangerous as Delta. It's less virulent than Delta. It's a common cold. You hear this a lot. Omicron is like the upper cold, is like the common cold. What we do not seem to take into account is that the world has gotten itself significantly far more vaccinated to fight Omicron than they were against Delta. One of the reasons that Delta really decimated populations across the world was that the penetration of vaccination was significantly lower than what we have right now. And I'm going to actually open up this question to Dr. Coetzee as well. So the real miracle, if anything at all, in the management of COVID-19 has been with the introduction of very, very what appears to be among the most effective vaccines that the humanity has ever produced. in what is most definitely a record period of time. And that was what I think is really saving us from Omicron. Not necessarily the fact that the disease has reduced its virulence, but the fact that we have managed to get a large percent of the population. What do you think of that, Dr. Kodzi? I'm not sure if she's there. Yeah, she is. Yay.
I am. Yeah, very, very good question. So I think you also need to look at the virus or the variant, the characteristics of the variant itself. But if you look predominantly at what we see with Omicron, in South Africa, it's our fourth wave, and a lot of people will have immunity. How long this is going to last, whether it's natural, whether it's a combination of vaccines with previous infections, there's a lot of questions that we still can't answer, but we are hoping that your T-cell immunity will protect you going forward. Maybe 10 years from now and still try to remember that something happened before and just start to produce antibodies and start to fight again. But that's a longer term thing that we need to look at and keep on our eyes open for. But I also think if we look at Omicron itself, as I've said earlier, I think it's a hit and run type of variant. It comes very quick, it escalates, give you a maximum infection rate, and then just as sudden as it came, it starts to disappear. A bit of a concern to me because, it's like a child that is naughty and all of a sudden that child is keeping quiet and you're always wondering what is that child doing in the background. But so yes, your vaccines is playing a role, your previous infections, but I also think it's part of the characteristic of the viral infection itself.
Perfect. Thank you, Dr. Kodzi. My next question is to Dr. Rupali. Even Dr. Singhal, maybe we can have a discussion on this. What do we think are the future course for the pandemic? We've now got, till now, we had subsequent viral variants that got progressively more transmittable and more virulent with every single, we went from the original Wuhan to the Alpha variant that was more transmittable, slightly more virulent. We really didn't get Gamma and Beta here in India, but then we went straight to Delta, which was not only significantly more transmittable, but also significantly more virulent. And then now we get Omicron, again, more transmittable, what appears to be less virulent. What do you think, both Dr. Rupali and Dr. Singhal? Are we seeing an aberration over here where we got lucky and we got a variant that is more transmittable but less virulent? Should we continue to be on our toes? Should we increase the amount of genomic testing, or we should? What do you think? I'll let Dr. Rupali go first.
Okay. I think for any virus, it's not a clever virus if it kills every host that it infects. So I think it's like a Darwinian survival of the fittest. It has to get less virulent as things go by. And that's what we saw with the influenza pandemic of 1918. So I think it's a normal course of it. Yes, it is more transmissible, but it is less virulent. So I think, like Dr. Kodzi also mentioned, it's like a hit and run virus. So it's going to cause a huge peak and then it's going to subside. And it may remain there in the background, but if it doesn't cause severe disease, it's going to be similar to flu. So I think it's kind of evolved into a more efficient variant, so to speak. So I think it's on its way out. It's similar to what is happening with influenza. Tanu, over to you.
Yes, I feel that the Delta was an aberration because, it got more transmissible and more virulent, which didn't fit in with the pattern. But my feeling is that nature is going to control the pandemic now. And most of the pandemics have lasted for 2 years. And now we are here at 2 years. And another thing which was noticed about this Omicron is that it is looking more like the seasonal coronavirus than, the SARS-CoV-2 in terms of many of its characteristics. So I don't know whether we may have a situation where it is going to become endemic and people who are having severe comorbidities are the ones who are really going to be more affected. That's what I kind of feel it will be. And sooner or later, we will have to kind of let go of all these extra precautions and masking, because that cannot kind of continue forever. That's what I feel. And I'm not even sure whether vaccinations will be required every year, because even with the booster vaccinations, it has not really done something very magical. I mean, they protect against infection, but after some time, their immunity goes away. So if the virus becomes less and less virulent, maybe only a small category of people will actually need vaccinations against this, the one who have comorbidities and who really need to boost their immunity, but other people may not. So that's what my thought is, that we'll have it endemic and we'll have it less virulent, and we'll all learn to live with it.
Something like, I guess, the annual flu shot that most healthcare workers and high-risk populations tend to take. I'll ask the next question of Dr. Gray, because she seems to have to treat patients who just get these persistent, they just don't clear the coronavirus. And we all know long COVID in immunocompetent individuals. What is your experience with long COVID in people with HIV, in AIDS, or immunocompromised individuals? And what do you think is the genesis of this problem?
Yeah, that's a good question. A great question. I mean, we haven't differentiated in the studies. I don't know if we've got enough information on long COVID in HIV infected individuals. But what we do know with long COVID is the longer, the more severe your illness is, and the people that were more likely to be ventilated or be in hospital or on oxygen are the ones that are more likely to have longer durations of COVID symptoms or long COVID. And so it's a function of how severe your initial infection was, that predicts the long COVID. And we see that if you follow people up month after month, is it the symptoms, most of the symptoms dissipate except for a couple, and the ones that seem to be maintained are things like chronic fatigue, the fogginess, of brain fog, things like myocarditis, and such. And so I think we need to differentiate. I think it's a good question, because there is long COVID is it an aftermath of a very robust immune response, or is there end organ damage from the infection itself that also contributes to the long COVID? And I'm not aware, maybe Angelique is aware, but I haven't seen any specific data on HIV infected individuals yet. And I think that should be, you've asked us a great question. Now we can go and look for it and then publish it. But thank you. I mean, it's a great question, which I can't specific answer at the moment. Angelique, your experience with in your practice?
No, I haven't seen any complications with COVID and or Omicron and my HIV patients. And yes, a lot of my HIV patients did get COVID, HIV, but I only have seen out of 120 patients, one patient, the lady last week, with that terrible, that ACE cough that you can get, but this is an ACE cough on steroids, She was coughing the whole time, that dry cough for the last three weeks since she had COVID, Omicron. So I treated her with anti-inflammatories and a bit of steroids, and she improved. But that's the only patient of all, even the 4 that was hospitalized. That's the only side effect I've seen, and it's not even HIV related.
Perfect, thank you. I guess my next question, I'm going to switch this around. I was going to ask Dr. Singhal, but I think she just dropped off. Oh no, there she is. I hear you. I'm sorry. What is it about COVID? We see all these type of, secondary manifestations, right? We've had viral diseases for some time now, but we've never seen a cytokine storm that just comes on the way, or we might have seen it. At least I'm a relatively young critical care doctor, so I may not have seen it, but I'm sure you may have. A cytokine storm that comes on with COVID-19. we normally see with bacterial sepsis, but not with viral sepsis like this. Or, this the multisystem inflammatory syndrome that you see in the kids, or in adults who, this long COVID. What are the long COVID manifestations? What is it about COVID that's doing this to people? I'll ask this question to both Dr. Singhal as well as Dr. Rupali. Maybe Dr. Singhal can tell us a little bit on the multisystem inflammatory syndrome. What's the genesis of it?
Yeah, so one thing is that just before that, it's just that this COVID virus attaches itself to ACE2 receptors, which are all widespread all over the body. So probably that is the reason why it kind of causes multiple organ manifestations and involvement of all organ systems. The other thing which is unusual, and those things are still being unraveled, is that it causes a kind of immune dysregulation. And the body's immune response to fight it goes overboard, which leads to the cytokine storm in adult patients, which comes in soon by the end of the first week or beginning of the second week. But in children, for some reason, is delayed by 3 to 4 weeks. And we know that this multisystem inflammatory syndrome is like Kawasaki disease, which is also hypothesized to be following other viral infections. So basically, it is kind of immune dysregulation, which leads to this kind of response and then leads to the multiple manifestations. The only difference between children and adults is that adults get it pretty fast, and lung is the major organ that is involved, whereas in children, it is a little late, and also lung is generally spared. So that is odd. Of course, we also see cases of multisystem inflammatory syndrome in adults as well.
Perfect. Dr. Rupali, I'll give your thoughts on the matter.
Okay, so I must say I agree with Tanu. I really have nothing much to add to what Tanu has said. I think long COVID, why it happens, what is the pathogenesis, the data is still evolving. And I think just very recently, there was a paper published, I think just about a month ago or so, where they've actually been able to define what is the immune responses in those who have long COVID versus those who don't have long COVID. So basically, the inflammatory switch that is supposed to go off after the acute disease resolves continues in some people at a lower level compared to those who it resolves rapidly. So the data is still evolving, and yes, it is a kind of, even long COVID is a bit of an immune dysregulation where what is supposed to happen doesn't happen, and it goes on smoldering in some people. I think. For those of us in the TB HIV world, we're kind of used to that with the iris, how it settles and it kind of pops up back again. And I wouldn't really, it probably is not a good example for long COVID because here it remains there, but it's on a lower level. But people start noticing it because they're still not well enough, to go back, and they still notice some changes. With regard to our patients and what we've been seeing, I must say we are still collecting data. We don't really have enough data, at least in India. So we've just about established a long COVID network to see what happens. In our HIV patients, I must say we have not really come across this just yet, but we probably have to do a complete evaluation to be certain of the cohort and the data that we're gathering. So we haven't really come across it very specifically or more in HIV patients. The cytokine release syndrome is not new, really. I mean, we see it very often with CAR T cell therapy. Those of us who are used to handling immunocompromised patients, it's something we do see pretty often. Well, maybe pretty often is a wrong word to use, but we do see it. It's not particularly new to infectious disease physicians, at least.
I do agree with you. So with CAR T therapy, it is a known complication, right? With something like, even when you see something similar when you get differentiations, a differentiation syndrome, when they get the ATRA and they kind of progress on and they have this massive cytokine storm. And we do expect it over there. In fact, I would say even iris is basically a cytokine surge due to a reactivated immune system. But, in immunocompetent hosts, means the bacterial equivalent is severe sepsis, septic shock, and that causes a complete collapse of almost every system almost instantly. But over here, we see almost complete isolated attack on the lungs and where, like Dr. Singhal said, it's probably where you get the maximum number of ACE receptors that have COVID particles that have COVID particles or COVID virions attached to them. So yeah, perfect. And you know what? I was just going to go to Dr. Gray on that. Do you see any iris when you see your HIV patients and you institute ART on them with COVID? Are you seeing any iris with that?
I mean, we haven't specifically initiated therapy while someone is got COVID. So we would wait for them to have to be asymptomatic before treating them with antiretrovirals or with TB treatment if they had TB. And so we would wait for them to be stable. I mean, I could imagine that if you do initiate treatment, you may get in a couple. I mean, it may not overlap because it could take a while for immune reconstitution. So it may not happen at the same time. But I think in terms of HIV and TB, one would initiate treatment once the patient was stable and no longer sick with COVID-19. I'm not aware of anyone who's initiating treatment at the same time as being diagnosed with COVID. I don't know, Angelique, do you know whether most people would probably wait to initiate treatment? You want to make sure that they.
Dr. Gray, your audio is a little low.
You want to make sure that they're counseled and that they will be adherent. So I think there's a whole process about getting them onto treatment once they've been diagnosed, and so you're not going to rush to start treatment immediately. Angelique, I don't know if you want to say.
No, I'm not really aware, Glenda. Not really. I'm not sure whether anyone else.
Thank you so much, sir. It's really a wonderful session, and I would like to thank all our speaker doctors for sharing such an informative session, and Dr. Roy, to you for conveying the session so well. We are actually flooded with questions, a lot of questions, but I'm really very sorry that we couldn't put forward all the questions. And I would also like to thank all our participating doctors for your active participation by putting forward your questions. And it is really a very honor to be a part of this session. Now, I would like to invite the director of CLIRNet, Mr. Raja Paul, for the vote of thanks. Over to you, sir.
Yeah, this is just awesome. It has been such an honor to be a part of this wonderful event. The event was so interactive, and that in the process, I feel I have also learned a lot. In fact, this has been a wonderful healthcare collaboration between the two nations, India and South Africa. We'll definitely see to it that we'll come up with more such global knowledge sharing that will definitely help the healthcare as a whole. I'm very much sure that the attending doctors must have also enjoyed the whole session. And so on behalf of CLIRNet, I would like to extend my heartfelt gratitude to all your esteemed panelists, Dr. Angelique Kwedzi, Professor Dr. Glenda Grey, Professor Dr. Priscilla Rupali, Dr. Tanu Singhal, and also our esteemed moderator, Dr. Overall Ray, for giving us your precious time. Thank you so much. Sincere thanks to the heads of the various departments who handled the event throughout. A wide round of applause, and thanks to all the participants who made the event a much more memorable one. Finally, I would like to thank all of you present here for making the time to be with us today and helping us make this event a grand success. Thank you, one and all.